Well, welcome. Tonight we continue our medical series. We're going to talk about some pretty amazing technology and the people who bring it to Milford. So why don't we start with introductions?
Hi, I'm Mike Cordetti. I'm a radiation oncologist at the Dana-Farber Brigham Women's Cancer Center at Milford.
And I'm
Steph.
Stephanie McCausland, and I'm a radiation oncologist working with Mike.
But now you work with a very specific type of treatment, correct?
That's right, right.
And if you don't define it, nobody will know what it means outside the medical profession.
Sure. So we're oncologists, we're cancer doctors, and we use X-rays to treat cancer. So just like X-rays can image cancers, we use high-energy X-rays to kill cancer cells. That's what we do. I don't know if Stephanie can explain it a little bit.
That's basically then, and as technology evolves, we get more and more focused into radiation. In the older days, we did the radiation, and we didn't have the same technology, so we had to cover a lot bigger area, a lot more of the body got exposed. But as technology increases and the machines get better, we are able to focus this high energy to exactly where we want with the imaging and technology. So that's what we do.
But it's not just, when we think of radiation, you have a specific area. You know, when we think of stereotaxic frames, you know, to me, that's what we injected stem cells into the brains of animals for research. But why don't you explain your specific type of treatment?
Sure. So both Stephanie and I are interested in lung cancer, and one way of treating lung cancer is with radiation therapy. There are three ways to treat cancer: radiation therapy, chemotherapy, and surgery. When lung cancer is confined to a small area, when it's just a small tumor, you can treat it with a special type of radiation. It's called stereotactic body radiation therapy, or SBRT. And this is a technique that's useful because it focuses a very small area of radiation at the tumor, and it does so without harming a great deal of additional normal tissue.
How do you, I mean, hopefully nobody will ever have to deal with lung cancer. Wouldn't that be,
Yeah.
I'd love to see you out of a job.
Right,
as
so
you
would we. Like to own a restaurant someday.
But you know, you come in and you have a patient with lung cancer. How do you decide between surgery, chemo, and radiation before we get into your specific type?
Sure. Well, first of all, in oncology, we have a team approach to every patient, and we work collaboratively with the surgeon, with the medical oncologist, and we generally have a prospective tumor board where we'll actually discuss cases before we actually maybe even see the patient. So we come up with an overall plan for each individual patient with every modality discussed. And so it just depends on, like as Mike mentioned, a very small cancer, lung cancer that's very early, has had other testing that shows it hasn't spread throughout the body, hasn't gone into lymph nodes, would be an excellent candidate for the stereotactic body radiotherapy. And that would be, we look at the x-rays and films, CT scans, and discuss it in our tumor board, and think that that patient would be a good candidate for the SBRT. Patients that have more advanced cancers, we can't focus, we wouldn't want to focus so closely for stereotactic, so we would use other modalities. Sometimes if it's too widespread, you may want chemo to shrink it before we do any radiation. Sometimes we do chemotherapy and radiation combined, and then maybe even plan for surgery afterwards. So it's a whole mix of different scenarios, and we work very closely with our colleagues.
Is there any specific area where you'd say surgery is preferable to chemo? I mean, when you think of, okay, I'm going in for radiation, okay, medium well, Zorch me, you know, the old days of, okay, they put you in front of a nuclear reactor, your whole body gets 9 billion doses. Those days are gone.
Right.
And you think of chemo where, okay, I guess the oncologist has the balance of, can I kill the cancer cells a little bit faster than I kill the patient and their stem cells. And then I think of surgery, where to me that seems if I can go in and just cut out a tumor. I mean, intuitively it sounds easier. So, well, I'm not the surgeon, obviously, so it sounds
Right.
easy to me. Is there any time when you'd say, if I had the choice, I would go with?
Right, and you know, this goes back to the idea of the team approach. We have a tumor board meeting, which is, you know, it's a boardroom where everybody sits around in a circle. There are pathologists, radiologists, so the folks that read the slides, the folks that read the films. There are medical oncologists who give chemotherapy, surgeons, thoracic, GI surgeons, depending upon whatever site you're treating. And then there are radiation oncologists, which is what we are. And we discuss each case individually to determine what's the most appropriate plan of action. So for lung cancer, an early stage lung cancer that's confined to one small area, and we're finding more and more of these types of lung cancers now with the advent of CT screening, which is something we can also talk about. It's amenable to a variety of different approaches. One approach is surgery, and there are different types of surgery that can be done, and you're going to have the surgeon on your show to discuss that.
Yeah.
And another approach is radiation therapy. And you know, one type of radiation is a focal type of radiation that we specifically deliver at Milford at the DFCI Brigham and Women's Cancer Center.
So now, when I think of, you know, the stereotaxic approach, feels like more of a rifle shot, where you're going to much higher dose, but really confined to a specific small area.
Exactly, exactly. That's why it has to be a small target. If it gets too large, and we're talking, if you have to think, we're dealing in 3 dimensions. So if you get a larger target and you're giving all the high dose radiation, you incorporate very high dose to even some normal tissue surrounding it, and it's too much dose to that area. So that's why we only use this for very focused, very
But now,
small.
I mean, are you talking 1 centimeter, 2 centimeters? What size of a tumor where you'd sit and look and say, ooh, a little too big for my rifle?
Exactly.
Well, I think that's an open question
Right.
for research right now, actually. And you know, it depends upon the individual patient and the scenario where the tumor is located, how we can sculpt the radiation. What we do is more like surgery than it is like technology, in that we have to make decisions about how to use our technology to best deliver as much dose to the tumor while not harming normal tissue. So depending upon where the location is, we can sometimes get away with 5 centimeters, 6
Really?
centimeters, and or
Holy
sometimes
moly,
we can
that's a
get
big mass.
It is, and
It is.
sometimes we have to only treat a very small area as well. It just depends upon the location and the individual idiosyncrasies of that patient. So.
And now, when you look at the lungs, are most of the tumors in the bronchi? Where do you find most of them? Because when I look up, I mean, we're involved in synthetic organs over at Heart, and when I look at esophageal cancer or tracheal cancer, much smaller,
Right.
I look at cancer in the bronchi, and it's like the numbers shoot up like crazy.
Well, it's in the parenchyma usually, or, I mean, you can have it in the bronchi itself, which is called an endobronchial tumor. Those are, I would say they're not quite as common as more of the parenchymal tumors that are in the parenchyma. But definitely the location, if it's abutting a major bronchi, is one consideration in using SBRT, because hitting, you have to hit a little bit of that bronchi, especially if it's a major bronchi. There's can be risk involved when you do that very focused radiation, give
But is
those
it,
high
Stephanie,
doses.
is it in the lobe itself that you see the cancers? Is it in the bronchi inside? I mean, I know this is
Could be
pretty
either one,
basic
right,
to
right.
you, but, you know.
Maybe you could explain.
Sure. So lung cancer, there are 2 types. There are 2 broad types. There's non-small cell lung cancer and there's small cell lung cancer. So
Okay.
it sounds pretty simple because it is. Some of the cells look in a specific way under the microscope, and the pathologist calls it one or the other. So we're talking about non-small cell lung cancer, which is amenable to this technique. Non-small cell lung cancer typically arises from the actual, not necessarily the airway, the bronchi, but it can. It can also arise from what's around the airway, the parenchyma. That's the scientific term for the rest. So,
Right.
Lungs have lobes, and it shows up on a CAT scan as a smudge on a CAT scan, and it's usually arising outside of the major airways. So.
And now, is it usually localized? At least you hope, but
Unfortunately
No.
not. Yeah. But more and more we're detecting lung cancers at earlier stages. And part of the reason for that is better imaging. All of the advances in radiation oncology, treating with radiation, come from the fact that we can see tumors, and that's from advances in CAT scanners, MRIs, PET scanners. And recently, Medicare has approved lung cancer screening with CAT scans for patients over the age of 55. So anybody that's a smoker that's smoked for quite some time. The technical definition is if you've smoked for, 1 pack a day for 30 years, even if you quit, or if you've smoked 2 packs a day for 15 years, around that amount, you should see your primary care doc about being screened, because we pick up lung cancers at early stages that are amenable to cure with focal radiation or with surgery by patients being screened.
now you use terms like CAT scan, PET scan.
Sure.
Explain to people, what's the difference?
Well, the CAT scan is, first of all, you have an X-ray, which I think most listeners probably are familiar with and probably have had, and it's a basic film. They used to have the film, and you
put it behind and you-
right, and you get behind, and now it's all digital. But that's the basic filming, and it doesn't give you a 3-dimensional view. So they do take different views of the
more of a
lung in order
slice
to
type
put
look.
right, just sort of a 2-dimensional view of the lung and other parts of the body. Sometimes the X-rays still are used for bones, and they still use them now for screening. If you go in the hospital for an operation, sometimes they'll do an X-ray. So that's the very basic. It doesn't show you as much in the lung as the newer technologies. And then you have the CAT scan, which actually gives you a 3-dimensional view of the lung, and it slices you. I say if you picture yourself as a loaf of bread, and you get sliced, or you slice the bread. That's sort of what the CAT scan does. It takes your body and slices it, and each part, so you can put that together and make a 3-dimensional picture. And then there's the PET scan, which is newer technology, and it uses a tracer, a glucose tracer, and what it does is the basic thing, if you can think of it, that the tumor cells take up a lot of glucose. They're very active, and the more active you are, the more you need sugar, just like the tumor itself needs more sugar, and it lights up. When it takes up the glucose, it will light up those very active tumor cells. So it's very, you're really able to see more of the tumor.
But wouldn't you also see stem cells? I mean, they seem like fast-growing cells.
You do see there's some active parts of the body. So the brain, it's not very good for the brain. It's you see in the heart is very active. The kidney's very active. You have the bladder that lights up. So those things that are really taking up the glucose are very bright, just as a tumor's bright in activity.
Now, you say that Medicare pays to scan my cat. That's a good thing.
Yeah.
Cats are good.
Right.
But if cost was not a question, would you prefer one over the other?
I think the question of cost it's always one that we struggle with, as insurance companies want more and more justification for
Right.
everything we do. Luckily for cancer, we're usually able to get what we need done for our patients. We try to use evidence in order to decide what type of imaging is appropriate, because there's always a cost that's associated with imaging with the wrong modality, using a PET when you're supposed to use a CAT
Is
scan.
it that much of a difference, Mike, in cost?
I don't mean cost. I mean there's a potential cost to the patient, and that you may be imaging inappropriately, and you may be acting on something that you shouldn't be acting on. So unless there's an evidence to suggest that for this particular type of cancer, this particular type of imaging is recommended or required, then we shouldn't
Is
use
one
it.
more safe than the other? Do I get less radiation when you scan my cat versus my pet?
Pets.
Well, different types of imaging do come with different amounts of radiation.
But seriously, if you're doing a 3D image, you know, if I'm taking a picture
Right.
of the loaf of bread
Sure.
Right.
versus 42 slices in the loaf of bread,
Absolutely, definitely.
I would think you get more radiation
You do.
with the 3D.
You do, and even with the 3D, there's different settings and different, you can, depending on how high quality picture you want or need, will require more radiation versus if you're just looking for some little, you know, just you don't need to detail it. The technician can lower the radiation dose so you don't get quite a crisp picture, and but definitely an X-ray itself is going to be lower dose than a CAT scan.
So when you look at surgery, it seems like you can perform it with a blade, with a scalpel. Are you performing surgery with an E-beam?
That's one way of looking at it, in that we're trying to look at a very small area and treat that very small area while not damaging or harming the areas around it. And there is a surgical thought to how to spare other areas while just treating and removing the cancerous cells from one spot. So,
Now, Mike, if you punch a hole in my lung, how do you fill the hole? You know, I'm sitting there saying, okay, wait a minute. So your surgeon goes in, cuts it out.
right,
I mean, my lungs are supposed to hold air, and now you put a hole in it,
right.
which is good because you got rid of the cancer. But what do you do then?
Right, so I mean the cancer is replaced by scar tissue most of the time, and it's a gradual process. The cancer cells die and the scar tissue replaces those living cancer cells, and most patients do just fine after that. That's not a hole. It's an area of the lung that may not be quite as functional, but luckily we all have a lot more lung than we
area
need in
than we
order to
need.
breathe. So,
Right.
Now, is it safe? And when I read that typically patients will go in to you for like 6, 7 treatments?
Usually, if we're talking about stereotactic radiotherapy, the treatments are between, in our center, it's between 3 and 5 treatments. And we decide that based on the location and size of the tumor itself. Ones that are more centrally located are close to the bronchi that we worry about. We give a little less dose per day per fraction, so we do 5 treatments. Ones that are peripheral out on the edge and really don't have a lot of airway involved and are small, we can give a little more dose per day and do the 3 treatments. So if we're strictly the SBRT, by definition is 5 or less treatments, and at Milford we will go between 3 and 5 using clinical judgment.
How does that compare to, like, I mean, you think of chemo and visions of in perpetuity going in and being injected and being ill. I mean, when you think of the traditional radiation therapy or chemo, how does 3 or 4 treatments compare?
well,
And I know there's no perfect
sure.
median.
No, I think patients tolerate this very well. They're pleased with the fact that they can be in and out in
Yeah.
3 to 5 treatments. In the past, even for these tiny lesions, we would need to treat for 40 days with small treatments each day rather than the big treatments that we currently give. And that was a real burden for patients to come in to receive their radiation therapy for the course of 2 months. And you know, it's a great thing for them to have that convenience.
Yeah, very limited side effects. I mean, they really come in feeling well. They go home feeling well. They maintain their activity. They really don't have to limit it. They'll go and do yard work, go do what they need to do for their daily activities. So they really don't miss a beat when they're undergoing the
So
radiation.
you don't lose all your hair and vomit all the time like you do in chemo?
No, no. I mean, there's really very, very minimal side effects. And the goal, one of the goals is to not limit your to maintain your lifestyle and your activity. And most patients with this treatment do just that.
That's pretty amazing.
It is.
Because, when you look at the, especially the kids, your heart goes out when you see them losing their hair and the fatigue and all the side effects. So you don't feel that when you're doing the stereotaxic radiation.
Not with that type of radiation at all. Yeah, it's usually very well tolerated, and patients don't even know it's happening. So,
Oh, that would be good.
yeah.
But it really then depends on how early you catch it.
Yes, absolutely. It's not a treatment that everybody can have, and with like Mike was saying, with the CT screening, it's hopeful that more people catch this earlier and be able to do some type of treatment like this, where they're really going on with their life and just sort of taking a break and doing the radiation and not having any real side effects. So, but you have to catch it early, and it has to be, amenable to that.
So realistically, now you're saying that, if I want a scan, I have to tell the insurance company, oh, I've been a big smoker,
I think your primary care doc is the person to speak to about that, or to any oncologist. I mean, we're happy to
Right.
Arrange if the patients call the cancer center. We're happy to help refer
I mean,
patients.
let's face it, a lot of us grew up. I mean, the Cohiba was my friend when I was young, till I had children who, now all of a sudden you start realizing, wait a minute, this cigar isn't worth, losing my children over.
Right.
But you start seeing people 50 years old or closer to 60 like I am, and maybe you get nervous that the sins of the past may come home and bite you. So for people like me, and I had the scare of my life last year when I had pneumonia and a little spot showed up on my lungs. For a week, I was waiting and praying I had pneumonia.
Right.
Luckily, at that point, that's what it was.
Right.
But what does the average person do? Do they go into their primary care and say, I'm asymptomatic, I feel good,
Yeah.
Yeah.
but I was a bad boy when I was young and I smoked? Or
Yeah.
I worked in a coal factory or something.
Absolutely. I mean, the number one thing that everyone can do is to stop smoking if they're still smoking, and that drastically reduces the likelihood of any kind of lung
I
cancer.
miss my
from forming.
Cohibas.
Yeah, well,
But
but the second thing they can do is follow up carefully with a physician who can make sure that those spots, if they're there, are addressed. Whether it's a spot that just needs to be watched over
I'm
time,
more worried
or
that how do they even know they have spots? I go in
Right.
and I say,
Right.
okay, Michael, I've been coming to you for years.
Sure.
And you've been telling me, give up your cigars or you will die early.
Sure.
And I, at 30 years old, I was immortal, right? At 40, less immortal, And then the kids come in and you're like, oh my Lord, I have to be serious about life.
Right.
But okay, so it's been a long time. I do miss my friend the Cohiba, but he's gone. How do I start? I mean, it's just, I don't want to seem like overly sensitive about my health,
Right.
but how do I look at my primary care and say, Dr. Stephanie, how do I know?
well, first of all, it's very, very important to give a full history to your primary care about your past. I mean, it's very confidential.
Sure.
You need to be partners and very comfortable with your primary care. You have to find somebody who can work as a team together. So presumably, if you have that relationship with your primary care, they will know that your history, that you did what you did when you were young, and there's no judgment as a physician.
Yes, there was his
And-
judgment. I was stupid, but okay, I'll admit it.
But it's a team approach, and so your primary care should have that record. It's important not just for cancer, but for other health issues that can arise. And if you're, not all primary cares are, that's not the number one thing they're thinking is, oh, you need a CT scan to screen for the lung cancer. But if it's something that you're watching the show and you're thinking about, it's something that you should approach your primary care and say, doctor, my past.
Please have the discussion.
And, right. And they'll say, I don't really think it's appropriate this time. Maybe you didn't have enough history, or, that's a good idea. But I think a discussion's very important, and as a team, you'll decide what makes sense.
But let's say I go in and I get scanned today, and he says, I can't find anything. That doesn't necessarily mean I have a get-out-of-jail-free card, right?
Right. So, if a patient does qualify for lung cancer screening, it would typically be done on a yearly basis.
Oh, so you do it every year?
Right. And that's just, it's for everybody's peace of mind. I mean, I think it's a good thing to make sure that over the course of time, nothing develops.
But when you say develops, does that mean the mass was small enough that you just didn't pick it up last year and it kind of grew and the threshold is now exceeded so you can pick it up? Or how does it start? If it isn't there when I'm 58, how does it start when I'm 59?
That's a great question. I mean, we see patients, they quit smoking 20, 25 years ago, and now they have their lung cancer. And that's a common presentation for lung cancer, that the smoking did the damage, the patient did the right thing by stopping, but at some point in the future, the changes that occurred as a result of smoking, the mutations that occur in the DNA of the cancer cells, are just, the patient's pushed over the edge, and the tumor forms after all those years.
So I'm sitting there with little mutants in my lungs, waiting for their time to come.
Hopefully not.
The good news is that that's not the case for most people, and one way to make sure that's not the case, if you do have a history of smoking, is to do the yearly CAT scans if it's appropriate for you. So
Now, I mean, this is a horrible question, but I'm going to put it to you anyway.
Sure.
Uncle Frank and Uncle Phil get mad at me when I refer to the little Milford hospital that I was born in, the little red building, because it certainly has grown.
It absolutely.
But there's always the perception, is this the real Dana-Farber? Or am I buying an economy ticket because I'm not going, I'm not going to the Binney Street, I'm not going to the Jimmy Fund building. Yeah. Am I going to get better treatment by traveling all the way to Boston?
So, I mean, that's a great question, and we as Dana-Farber physicians take that very seriously. I think we have a unique model for satellites, where other hospitals do have a lot of satellites and may not. Everybody has a different model, but we're very, very integrated into the Dana Brigham system. We are true partners with our colleagues in town. We have conferences with them weekly. We discuss the cases with our colleagues, with our lung colleagues in town. We specialize as they specialize. And in fact, sometimes, once in a while, there'll be something that when we discuss a particular situation, we feel that they may be better in town, and we'll recommend that they go into town for an opinion, or for our partner to see them, or maybe even get treated there. But we take it very, very seriously that you will have the same experience, the same treatment if you come here or if you go into town. And if we don't feel we can give that to you, we will absolutely 1,000% send you into town to get that treatment.
What would be the specialty? What case would trigger you saying, go into town?
Right. So, I mean, for one thing, they in town sort of start. They're the ones who they start treating a tumor that's very close to the big bronchus that we were talking about, and they did the study with it and make sure that it's safe, and how they're doing it is working. And so for those cases, we were sending patients into Boston, and then once they've done it, we will present our cases to them. They look at our case, look at what we're doing, and then everybody okays it. But they sort of are the ones who will start start the
So it's
program.
really kind of
Yeah,
a
that's what happened.
specialization that you've got surgeons, you know, I think of a specialty, that they see more of this type of patient because they're in Boston. It's not skill level or anything on that line.
Well, I think, you know, as far as the partnership, I mean, we both work in both locations. The referrals go both ways, so we'll refer to Boston, and Boston will refer to
Right,
us depending upon the appropriate level of care and how we feel the patient would be best served. And we all have different specialties and different interests, clinical interests, what we're best at. So, you know, if I know a particular physician at a different site would be the best physician for a patient, I'll always refer the patient to that best physician, whether it's within the Dana-Farber Brigham Women's system or not, whether the patient's in Boston or whether the patient's at Milford. And this is how practices probably should evolve everywhere, that you refer to whoever you feel is best for the patient. And luckily, it's felt that you know, we get a lot of referrals from Boston to us because the feeling is that we'd best serve the patient, and we have a good partnership both ways.
And in fact, we start programs as well where they institute it, so we have a give and take relationship. So sometimes they're starting something, sometimes we start a program where they learn from, and so we learn from each other, but we are one entity. And certainly, if even it, like Mike said, if it's something that I don't know an example, but if you feel like we go outside a system, if it's something that needs to do that, it's number one is the patient's care.
Well, it would seem pretty unique to have to go outside of the Dana-Farber system.
Right. I mean, I I'm just
I love the attitude. Mike, I love the attitude.
It's rare.
That you're going to do what's best for the
We're
patient.
doing what's best
it's
for the
very rare.
patient.
But when I think of Dana-Farber,
Right.
I would think more, the Gazinta is a lot more than the Gazauda.
Yeah,
It's
yeah.
very true. It's very
yes,
true.
Yes.
Yeah,
And
it's
it's funny because, now almost a dozen years ago, my sainted mother, who's 91, went in for her normal checkup, and they came out and they said, we can run all the tests, but we're telling you she has intestinal cancer. And, immediately, this is my mother. All the emotions, everything goes through. But I saw the effect on her that she could stay in her Milford hospital.
Right.
To this day, it's not the oncologist, it's Dr. Mona. She always takes care of me. And it's been year after year after year that she goes in and Dr. Mona takes care of me. To my mother, there's no team. It's her.
Right.
She's the one that took care of me from day one.
Yep.
Every 6 months or whatever, I go in, and she takes care of me again. But there seems to be, I hate to say it's a placebo effect, but just staying in your own little town has got to have an effect on the mental state of these people.
I mean, at least for radiation therapy, it makes a huge difference. Well, we've been talking about SBRT, which is 5 treatments, and
Right.
that it's hard enough to travel far away for 5 treatments. A lot of the time, we're treating patients with 20, 30, 40 treatments, and to have to travel to a location that is far away, I mean, that's a big strain. And to have the opportunity to have high quality care that's of the same caliber as what you'd get in Boston, I think that really helps folks to have that in the community.
Now, I'll put you on the spot. You're from Boston.
Yes.
So you come all the way out to the center of the universe here in Milford.
So
I'm Westwood.
And you're
so I'm
Westwood,
That's
so-
not too far. That's
I
just
mean,
109.
You're kind of, you can go
109.
either way,
Yeah,
but
I'm 109.
you're right
He's
there.
in Boston.
So I live in South Boston, and here's the thing. Here's the thing. It takes me about 40 minutes to get to Milford. It takes me about 35 minutes to get to the Brigham from South Boston. So it's the same to me. It's about the same. It's just the speed I'm driving.
But, realistically, you could practice in either one.
Right. And I do work in Boston at least one day a week, so it's convenient to have the home there right
So you
next
have
to the highway. So there
So you have to go to the Farber.
Right.
At least you don't have to go to man's greatest hospital. I can't
Right,
say that. They
yeah.
get mad.
yeah.
What makes the treatment here so unique? I mean, people love the Milford Medical Center. And as much as I joke about the little red hospital that could, or the little red hospital that did, there is something magical when I go into the med center.
Well, I mean, the hospitals, we're talking about the cancer center is, I mean, it is a magical place. I mean, it's just, you're getting all of the treatment that you would in town, but you're getting it close to home. And the people that work there are just, they're mostly local.
And they don't
people,
leave.
And they're unbelievable. I mean, the therapist said the therapists are ones who treat you every day and set you up and you see every day. They're just extraordinary people, and every patient I have just can't believe the care they give, the hope they give people, the just an ear to listen to, and maybe it's a small town, that's part of the small town environment, but still getting the big town technology. But it's hopefully none of the listeners will ever have to experience this.
Yeah, I hate to say it, but I hope I never have to come visit you.
Right,
But
it is, I mean, it's just amazing group of people that we work for and with, and I think we all feel extremely, extremely lucky to have the opportunity to work in Milford and with these amazing people.
well, it's going to be a good environment because obviously, with the caliber of physicians that we have here, you could go find, well, you can work in Boston because you're there already.
Work it, yeah.
But if it wasn't a good place to work, somewhere where you take pride in, because the money will be the same. So it can't be the money drawing you out of Boston. It's got to be the pride of what you do or how you do it.
Yeah, it's an amazing team that we get to be a part of, and something that you don't get in Boston and in a lot of other centers. We have grateful patients that want to give back and they're part of the community, and we have a survivorship party every year, and you see everybody come, and it's almost like this survivorship family. So patients know each other, they know each other from the community, from their experience, fighting their cancer, and they all come back and they all get together, and it's something that you don't get at a larger place where those connections aren't made. So.
Now take a minute and talk about the technology. Because, we all hear, okay, we get nuked. In I go, medium well, okay, but how does it really work? So many people have asked questions like, is it a little ball like I see on TV that shoots down? Explain the actual technology.
Well, I mean, you start first with what's called a planning session, a simulation, where you actually have a CAT scan, and we reconstruct you three-dimensionally. We highlight the areas on the CAT scan. We actually draw what we want to treat on the CAT scan, so three-dimensional picture of what we want to treat. And then it goes to the physics team, who use very complicated computer algorithms in figuring out what angles that the radiation needs to come into, right? What shoot this area, how high of an energy it needs to go, which techniques we need to do to accomplish getting that radiation to that area without getting exposure to the normal tissue. And so this is what the physics team does, and they come out with a plan that we look at, and we try to work together and say maybe we should do a little more in this area, a little less here. So we come up with a plan that the physics team and the physicians agree on. And then once that happens, as the patient comes back, they actually have a dry run in this big machine in a big room. It's a little intimidating, but the machine is turning exactly the way that was planned by the computer and angling at different angles the radiation. So it becomes a focus beam, not as focused as we were at the SBRT, but a very limited area, and we know exactly what it's hitting, what's getting treated, what normal tissue's getting treated.
When you say a focused beam, what is being focused? The
The-
radiation's coming from where, and how does it get?
So the radiation's coming from the head of a machine. It's produced by electrons, accelerated electrons that that bounce off a metal and are produced by photons are produced. You don't see it. It's not a light. You don't feel it.
It's not like TV where you see the
You don't
green
feel
laser
it.
coming
no,
out.
No, you don't feel anything. You don't see anything. You would only know it if you had a radiation badge that's saying that you're getting the radiation, and it's a big machine that sends this, and it can be modulated with different leaves that come and close, open and close to shape the beam. You don't see it. It's all computer driven, and then it moves the way that the computer has programmed it to
Now, what do
move.
you do with people like me that can't sit still? Do you bolt us down? I mean, I keep thinking, here you are with your electronic scalpel, but you're counting on the fact that I'm not wiggling.
Yeah.
How do you keep me from, I mean, our studio manager here, Liz, got rid of chairs because she said, I can't keep you from slouching. There were chairs I really liked, they were really comfortable. But
funny.
I'm thinking, okay, you set everything up and then I wiggle.
Right. Good question.
Yeah, it's always a challenge to keep patients stable on the table, but we do a couple of things. Patients, when they come for their planning session, the first time that they come to plan the radiation, we get a CAT scan to see what their anatomy is, and that's how we decide how to plan the radiation. We also place tattoos on the patient's skin, and those tattoos are indexed with a laser system. So you're aligned with GPS coordinates in the planning
So if
room
I
and
do
in the
move,
treatment room.
the computer can move with me.
Well, that technology isn't quite there yet, but eventually it
Yes.
will be like that. But what we do is actually, when you're on the treatment table, we take X-rays to actually see all the anatomy on the inside, and sometimes even CAT scans on the actual treatment table itself to make sure that the patient doesn't move. And then there's a video camera system to make sure that the patient stays in the same spot. So.
Now, most of your patients older? I mean, what's the median or what's the typical? I hope they're not kids, but
No, we don't treat pediatric patients. So if they are pediatric, they'll go into Boston to be treated. So we don't do pediatrics. But the average age is 65, 65, do you think? 70?
I mean, I've had
65?
18 through 96 in
Yeah.
my practice, but I mean,
Has cancer. It's a
Yeah.
typical.
cancer
know.
skews towards an older age.
sure.
group,
Well, I mean,
sure.
we've had more chances to do bad things.
That's what I say.
You know, I mean, you
The
think
older
of an
you get, the-
18-year-old, they haven't had enough years to screw up.
Right. That's just what I say. Every year is another year.
Do I dare ask,
No problem.
the success rate getting better in treatment?
Sure. So, what we've been talking about is the focal radiation to the small spot, SBRT. The stereotactic radiation has a very high success rate. It's over 95%.
Wow.
And we're able to take care of that spot.
Is
with-
that
with
because of the
pretty good confidence.
technology or because the diagnostic ability is increased, or is it a combination of both?
It's definitely a combination of both. The fact that we're seeing it at a smaller stage so we can treat it just to a very small area with technology that wasn't available 20 years ago. So it's everything all together.
What made you go into this field?
Well,
I mean, if it was me, I'd want to be a pediatrician.
Well-
Right? So I get to play with kids. And they're not too, I hate to say it, but the indications aren't severe. I can deal with the bloody noses. Boy, you're taking on people who have to be in an emotionally stressed. I know when they said they found a spot, I wasn't jumping around saying, yay, what a good day it is for me.
So with me, I'll start. My mother was a pediatrician, And I decided I don't want to be a pediatrician. She got calls at 1, 2 o'clock in the morning every night,
But you
almost
get to
every
play with
night.
the babies.
And definitely not for me. And my father actually was a radiation oncologist. So, and he said, let me get this right. You can cure some, you can help many, and you can comfort all. So that was his own saying, and it's very true. And I know the reward he got from it and how fulfilling it is to help people in this way. And so that's what made me actually explore this field. And I don't think any of us could think of doing any other field of medicine. I speak for myself. You just meet the most amazing people. The patients, I learn from the patients every single day. It's just, I feel it's a gift that they come to me and give me, and and we have the time to really get to know patients versus a primary care where you have the time constraints.
Now it's every
So
13 minutes or?
Right, we're very lucky. We get a lot more time with everybody and really get to know people as people, and so my father brought me to the field, but the field kept me here.
That's inspiring. I love that. I would reiterate the ability to cure some, many actually, the ability to palliate and help many as well. I think that's what really drew me to the field from a patient perspective. I also had a scientific interest. I did a PhD in cell molecular biology, which I guess is your field as well. And oncology, it really fit well with my research interests.
But when I'm doing the MoBio, sure. I'm not dealing with, okay, when my culture gets contaminated, or, I lose the cells, okay, I'll split some more and keep going. I don't have to deal with the patient.
Right.
I mean, a friend of mine was involved in some of the clinical screening on pediatric indications. I couldn't imagine. I couldn't say no. If I had the 50 children, I'm going to say, these get the placebo, these get the active.
Right.
I can't imagine I wouldn't wake up every morning thinking about not the 50 I helped, but how do you get over the one, not that you can do anything about it, but
For study or for pediatrics?
if I come in as a patient to you, and I'm the one that you can't help, that's got to be incredibly emotionally just draining.
But like my father said, you can comfort everybody. So I always feel that I can do something for a patient. And when I leave the room, I honestly always want to feel that I did something. It may be big, it may be little, but I feel like you can always give something.
So if even if it's just palliative care where you're saying, I'll make your life a little, for the time you have.
Yeah. Or just somebody to talk to, or just listen to, or figure out maybe, what you can do to feel better, get social services involved, help out in getting a nurse to come, just getting somebody to talk to. As comes back to what my father said, you can help basically everybody. You can comfort everybody. So you're gonna, and my father said cure some, but that was many years ago. So I said we can
Cure
cure
more.
more now.
The sum is
Right.
bigger.
So the saying gets a little different, but it's not, everybody's not gonna be somebody we can cure or even radiate, but we
Now,
can
if I want to
do
be a
something for
radiation oncologist, I mean, besides going to school till I'm almost ready to retire,
you, basically.
I mean, it just amazes me.
Right.
And how, tell me, you did your undergrad, then you did med school, so unless you're independently wealthy, you're now up to hawk about here, then what?
In my instance, I actually did a PhD, which helped to pay for the MD, but it took an
It's
extra.
one of those
took an
mud
extra-
floods that you
Right.
really
There you
say
go.
never wants to leave academia.
Yeah, but it took an extra 4 years then, so you're right. I mean, it pushes everything back. Then you do an internship, which is kind of what you see on Scrubs or those TV shows where everybody's rotating around the hospital and not sleeping. And then after that, there's a residency in radiation oncology, which is intensive introduction to physics, biology, and the care of patients in the radiation oncology clinic in that setting.
But even if you don't do the MD, PhD, the Mudfud role,
Sure.
you're still putting 5 more years minimum after your bachelor's,
Absolutely.
Well,
while everybody
more
else
than
is
that.
out there working.
Right, 4 years of medical school and then 5 years after medical school.
So it's 9 more years.
Right,
Right.
You are almost ready to retire by the
pretty
time.
much.
It's true, yeah.
And now
It's a
you see
commitment.
more and more people not, I mean, in your line of work, I don't think you can go out and just set up an office very
Right.
easily and maintain the equipment.
Right.
Right.
But you see more and more physicians working for places like Tri-County. Is that a growing trend that you see?
I think in healthcare itself, I think it's become quite complicated, and so these, I mean, like you said, for us, it's a little different because we never really could just hang out our own shingle and and bring patients in.
Let's see,
so,
after
but-
paying for, 50 grand a year for undergrad, so that's a couple hundred. Paying for med school, you're up to 400 or 500. And then you got 5 more years. Oh, let's put out $2 or $3 million to set up our own little practice.
Yeah, nobody can do that. So, yeah.
So does it really allow you to spend more time with the patient that way? So if you're not dealing with all of the admin and,
Right, and I think just our field in general, we allot an hour per patient.
Oh, wow.
So we're not putting the slots. We don't have to, we don't have this pressure to, see people every 10 minutes. So we actually do have hour slots for every new patient, 30-minute slots for just follow-ups. So it just how our schedule is and what we do. It's complicated. I tell patients at the beginning of a consult, it's not just getting to know your cancer, but getting to know you, figuring out what you need. It's not, it's a whole person, and it takes a long time to build a relationship. And I think we're very unique in our field. I don't know of any, there may be other fields, but to allow that time to really get to know people is very unique. And then we see everybody on treatment, we see them at least once a week. And so
once a week?
while they're on their treatment, we talk to them and see how they're doing at least once a week while they're on treatment.
Well, they're alone. I mean, if I can drive down the street, to the Milford Medical Center versus, I'm just thinking once a week driving into Boston. I used to commute to Boston. As long as I left at 5:30 in the morning, 45 minutes, I was at the lab with my coffee.
Right.
If I left at 7 o'clock, it was like an hour and a half. So I got to believe my tension level and everything, if I got to do that every week,
Yeah.
it's got to be a lot lower if I can just drive, even with Milford traffic.
Yeah, could be bad, as we know.
That's pretty amazing. Now, when you look at the patients, once they're treated, and they're the 95, I want to be the 95%. I don't want to be the 5% that has to come back. But on the 95%, how often do you see them, or do you push them, do they get put back to their primary care?
No, we follow the patients that are treated with SBRT for the early stage lung cancer forever, essentially. So it's every 3 to 4 months for the first year and the second year, and then we'll spread it out longer and longer and longer as time goes on. And we just keep following them with repeat scans, and most of the time they're just social
What's the
visits.
recurrence rate? I mean, once you zap, okay, you've converted my tumor into scar tissue. What are the odds it comes back?
Well, I mean, depending upon the type of tumor, but in general, a good number is 5 to 10% for SBRT, which is the technique that
Well,
we've
actually,
done.
though, but you're saying that's 90 to 95%
95%
that don't come
that
back.
don't come back.
Right.
So 5 to 10% come back. That's the recurrence rate.
That's pretty impressive.
Yeah.
Yep.
I mean, that's really exciting when you start thinking about, the old days of what people had to go through
Definitely.
Definitely.
and how important is the family involvement when people are going through the treatments?
I mean, I think it's everything. There are even studies that show that if you're married, if you have more family support, you're more likely to do well with your cancer diagnosis. you have that support to drive you back and forth and to tell you to go to the hospital when you need to and to do all the things you're supposed to do.
Well, I remember my mom, I mean, she's going through a really tough time when she's
Yeah.
just been told she has cancer,
Mm-hmm.
but she was home. You know, we were having dinner together every night. It just seemed, to, again, ease the, you know, the anxiety of what's going on.
But that's what's nice about Milford, and family can be defined in many different ways. So it's not just necessarily a mom or dad. It can be really good friends. It can be the community itself. And so in Milford, and that's it's such a strong community, and we get to know the patient and figure out where their support can come from, and try to get even a community involvement if they need that. And so some people aren't as fortunate to have such a strong family, but like I said, family can come from many different levels.
Well, I think it's hard too, because as a friend, I want to say something, Stephanie, but I don't know what to say. You know, I had a friend going through it, and candidly, I had no idea, but I went up and said, if there's anything I can do, don't ask, just tell me. I didn't know what else to say. You know, what else can you say at that point? You know, good friend, you shouldn't have to ask me for help.
Right.
You know, but I do want to offer it,
Right.
you know. Any last words for people?
I just want to thank the community for allowing me to practice here, and I feel honored, as I said before, and every day is a treasure.
Yeah, I want to thank you for having us on the show so that
Right,
we can talk about what we do. So it's been great.
Well, we are incredibly fortunate to have the caliber of medical treatment here in our own little town. So from the community, we thank you for bringing it and taking care of somebody like my mother, because I know it's not just Dr. Mona.
She's pretty
She's
good,
great,
though.
though.
Yeah, we all love
But
Dr.
you know, you
Mona.
mentioned that there's a team.
Right, it is.
We don't
yeah.
see the team
Right,
because, you know, we just see her,
right.
but I can't ever express the gratitude that I've had my mother for 12 years. You know, and hopefully a lot more.
Yeah,
She's only
absolutely.
91. You know, she's
Young
91
stuff.
and going on.
Young chicken.
But, you know, as always, I hope you never have to see the business end of the people who take care of our families. Let's hope nobody has to deal with lung cancer, and someday we put them out of a job,
Absolutely.
and that's what they're hoping for too. But the good news is you can't get better treatment than you get here at the Dana-Farber and at the Milford Medical Center. You know, it's grown from the Little Red Hospital that did, not wanted to, but actually did grow. Frank, Ed, Phil, our hats are always off to you for putting together an incredible medical center and maintaining the environment that keeps top-rated physicians here. So to our 6 loyal viewers, as always, good night, may God bless, and let's hope tomorrow is a healthier day than today.
Thank you.
Not too long since I've been home.